Now, the very first question is about a homeostatic mechanism to tackle hyperammonemia, especially in brain. And here, actually, what happens, the ammonia which is produced in brain, and not only in brain, anywhere in the body, it is extremely toxic. So this ammonia has to be detoxified at the earliest, right? So this ammonia has to be detoxified. Now, what happens, this ammonia cannot be transported as such. So firstly, it has to be converted into a substance which is easily transportable, and this is actually glutamine. So ammonia which is produced in brain or other tissues, it is converted into glutamine, and this glutamine then enters the blood. Clear? So this enters the blood and it reaches liver. Now in the liver, the glutamine, it releases the ammonia, right? So here the glutamine is again broken down into ammonia, and this ammonia in liver undergoes urea cycle, and here it is finally converted into non-toxic urea, which is excreted through the kidney, right? So this is a simple method of the way how which the body get rid of ammonia, which is a highly toxic substance. So in brain and other tissues also, it is converted into glutamine, right? Remember, in skeletal muscle, it is converted into alanine, right? So if the question is about, say, skeletal muscle, please mark the answer as alanine. But in brain and rest of the tissues, it is converted into glutamine, which is taken by the way of the blood till the liver, where this glutamine, which is actually the carrier of ammonia, it will release the ammonia into the liver, and this is how you see the toxic ammonia is transported to the liver in a non-toxic form. So if someone asks you what is glutamine, you can say that it is the storage or the transport form for ammonia. Clear? So this you can remember. So the question usually which comes in the exam is mainly about liver, and since the liver cannot do the urea cycle, so it is highly dependent on liver, and therefore its job is to transport the ammonia in the form of glutamine. Glutamine, once it reaches the liver, it will liberate the ammonia, and then liver has this capability of converting ammonia into urea, and the process which do this is the urea cycle. So urea cycle is extremely important because it converts toxic ammonia into non-toxic urea, which is then forwarded to kidney, and it is how the urea is thrown out of the body in the form of urine, right? So this is a very important pathway, urea cycle, because it gets rid of the ammonia which is produced in the body, right? So if the question is about like this, how the ammonia is transported out of brain, the mechanism is glutamine. And if the question is about like how the ammonia is excreted out of the body, then your answer will be urea cycle with the production of urea in the liver. Clear? So please remember this basic thing, and this is one of the favorite questions in exam. In majority of the exams, whether FMGE, NEET, PG, in one or another way, this detoxification process is always asked, right? So in brain, we can see the ammonia, it gets it reacts with glutamate and it forms glutamine. This glutamine will travel all the way in the blood to the liver, where it will again liberate the two components, that is ammonia and glutamate. So The process of formation of glutamine is glutamine synthetase. As the name suggests, synthetase. So means there is synthesis of glutamine. So the enzyme which is responsible here is glutamine synthetase, and for breakdown of glutamine, the enzyme which we need is known as glutaminase. Right? So these are few enzymes: glutamine synthetase for synthesis of glutamine, and glutaminase for breakdown of glutamine, so that finally ammonia is released into the liver. Clear? So this is a very beautiful question and asked many number of times. Then moving forward to another question, it's like after a fatty meal, a person has taken fatty meal, but in that person there is deficiency of lipoprotein lipase. So it is written as LPL. Now, if a person who is having lipoprotein lipase deficiency, and if he consumes a fatty meal, which of the following will be raised in the blood? Now here we need to remember few things. Number one, person is taking fatty meal. Clear? So it means this is exogenous lipids, because it is being consumed in diet. So this is exogenous lipids, number one. For exogenous, because they'll be absorbed from the intestine, body needs chylomicrons. Right? So chylomicron is responsible for transport of exogenous lipids. This is one thing. Now what happens? These chylomicrons, they are composed of triglycerides and some amount of cholesterol, and there is covering of ApoB48, because we know that the lipids, they are hydrophobic, they are non-polar, and they cannot be transported in the blood. So they need a hydrophilic or polar covering of proteins so that they can be easily transported in the blood. So what happens in chylomicrons? There is triglycerides, right, which is the main component of exogenous lipids. There is slight amount of cholesterol, and there is ApoB48. So remember, B48. This is for chylomicrons, and chylomicrons are concerned with exogenous lipids. Exogenous means which are coming from outside the body in the diet, right? So this is exogenous lipids. So this is the structure of chylomicron. And if I show you it in the form of, say, component chart, so say this is the triglyceride, right? So this is triglyceride and very less amount of cholesterol. So this is the cholesterol. Clear? And there is ApoB48, just for demonstration purpose. So this is ApoB48. Clear? So this is somewhat the look of chylomicrons. Now what happens? This chylomicron is acted upon by the enzyme lipoprotein lipase. And the function of lipoprotein lipase is to remove triglycerides. So what it will do, it will remove triglycerides from chylomicrons, and then the chylomicrons will get converted into chylomicron remnant. Right? So it will get it converted into chylomicron remnant. Now if I draw the diagram of chylomicron remnant, here the triglycerides will be less in amount, but the amount of cholesterol will increase. Okay, so and obviously there will be ApoB48. So what has happened? There is release of triglycerides from chylomicrons, and then it becomes chylomicron remnant. So this is the normal process of exogenous lipids. Now, the question is about the deficiency of lipoprotein lipase. If there is deficiency of lipoprotein lipase, what will happen? Obviously, chylomicrons will not be broken down into chylomicron remnant and the level of chylomicron will increase. Clear? So, for this MCQ, your answer will be chylomicrons. And why chylomicrons? Because the question is discussing exogenous lipids. Clear? So it is discussing exogenous lipids and therefore the answer has to be chylomicrons. If the question was about endogenous lipids which are synthesized in the body, in the liver, then your answer will be totally different, right? So this is about fatty meal, means exogenous, and we know that exogenous lipids are transported in the form of chylomicrons, and lipoprotein lipase, yes Chaitanya, you are absolutely right. So if there is any deficiency of lipoprotein lipase, there is no breakdown of chylomicrons and hence the level of chylomicrons will increase. Clear? And for the time being, to avoid confusion, I am excluding the transport of endogenous lipids, right? So for the time being, this is all about exogenous lipids and this is the simpler format for explaining. Clear? So if there is deficiency of lipoprotein lipase, there will be increased level of chylomicrons. Fine. Then moving to next important question, that is source of melanin. Now here, very good Chaitanya, you are absolutely right. So source of melanin. Now there are two terms. One is melanin and another is melatonin, right? So student, they usually mix up between the two similar, almost similar sounding terms, melanin and melatonin. Now remember, melatonin is derived from the amino acid tyrosine, whereas melatonin comes from tryptophan. Clear? So this is tryptophan. So here you can remember TO, which is similar. Yes Chaitanya, you are absolutely right. So melatonin is derived from tryptophan, melanin is derived from tyrosine. So please try to avoid the mistake because many students, they usually mix up in exam. So melanin is coming from tyrosine, right? So tyrosine giving rise to melanin. Now tyrosine is very important because not only melanin, there are many hormones which are synthesized. Namely, you can see thyroid hormone, you can see catecholamines, right? Obviously melanin. So these are few important substances which are synthesized from tyrosine. So remember, thyroid hormones, catecholamines, melanin. Okay, so this is the importance of tyrosine. So very valuable. Now if the tyrosine level in the body is normal without any external supplementation, deficiency of which amino acid is ruled out. Now here we have to remember that what is the source of tyrosine. So phenylalanine gets converted into tyrosine and the enzyme which is involved here is the phenylalanine hydroxylase, right? So normally if we have sufficient amount of phenylalanine in the body, phenylalanine hydroxylase will convert it into tyrosine. So since tyrosine is synthesized in the body, it is non-essential. because we don't want it in the diet. It can be synthesized in the body. Yes, phenylalanine is essential because it cannot be synthesized in the body and it has to be supplied in diet. So if somebody is having enough of tyrosine in the body, it means there is enough of phenylalanine which is being supplied in the diet, and there is proper functioning of this enzyme, that is phenylalanine hydroxylase, which is converting phenylalanine into tyrosine, right? So the question is very straightforward. If there is enough of tyrosine in the body, it means there is enough of phenylalanine in the body, and therefore enough is getting converted into tyrosine, so there is no deficiency of tyrosine in the body. So this is an important fact here. And if there is deficiency of this enzyme, phenylalanine hydroxylase, the condition which develops is known as phenylketonuria. I think a very basic term, most of you must be knowing already. Okay, so this is important thing here. Now, a patient is having photophobia, right? So this is ocular finding. There is sensitivity to light, and there is increased thickness of palm and sole, and that is known as palmoplantar hyperkeratosis. So this is a cutaneous finding. So there are involvement of two systems: ocular, that is eye, and cutaneous, that is skin. Now there is deficiency of the enzyme tyrosine aminotransferase. So tyrosine aminotransferase. Now what is the diagnosis? Now obviously, if there is deficiency of this enzyme, there is high value of tyrosine in the body. So this condition will be known as tyrosinemia. So this condition is known as tyrosinemia. But there are many enzyme deficiencies which can result in tyrosinemia. So this is classically the type 2. So this is classically type 2, and in type 2 tyrosinemia, there is deficiency of the enzyme tyrosine aminotransferase, and therefore tyrosine cannot be converted into 4-hydroxyphenyl pyruvic acid. So there is no conversion of tyrosine to 4-hydroxyphenyl pyruvic acid, and obviously if there is deficiency of this enzyme, the tyrosine level in the body will increase, and that is known as tyrosinemia type 2, right? So I think everyone knows that emia means in blood. So there is high level of tyrosine in the blood, and because of the enzyme tyrosine aminotransferase, you will specifically label it as type 2. So here we can see this is the enzyme tyrosine aminotransferase, right? So this is tyrosine aminotransferase. In short, you can remember TAT, and this is converting tyrosine into 4-hydroxyphenyl pyruvic acid, 4-HPP. And if there is deficiency of this enzyme, the condition is hereditary tyrosinemia type 2. Please remember this much, and I'm just excluding the other types for the sake of avoiding confusion, right? So for the time being, just remember tyrosine is not converted further into hydroxyphenyl pyruvic acid, and therefore there is accumulation of tyrosine. The condition is tyrosinemia type 2. Okay, and this is also known as oculocutaneous syndrome. And why oculocutaneous syndrome? Because there is photophobia and there is hyperkeratosis of the palm and soles. Clear? So this is type 2 tyrosinemia. Just remember this much. Then moving forward to another question, a boy which was born out of consanguineous marriage, his mother, like she noticed that there is change in the color of urine, and as per the lady, she has observed dark black color on diaper when the baby was when the child was small. Now I think most of you, just looking at this particular clue, you can answer it as a case of alkaptonuria, right? So the urine turns dark in color on exposure to atmosphere. That is one very classical clue for alkaptonuria. But here you can take one more important point, that is consanguineous marriage, which occurs in relatives, and this type of clue gives us an indication that this is autosomal recessive pattern of inheritance. Moreover, grossly or on a general note, you can also remember that most of the enzyme deficiencies, they are taken as autosomal recessive inheritance pattern, right? So if you have any question about inheritance pattern, and if you don't know the answer, if you see if that condition is related to any enzyme deficiency, you can mark autosomal recessive inheritance, right? So here also there is a deficiency of one enzyme, because this is classically a case of alkaptonuria. Clear? So alkaptonuria, and alkaptonuria is because of deficiency of which enzyme? I think most of you can answer. It is not that tough. So this is homogentisic acid oxygenase, right? So this is homogenic acid oxygenase, and here the homogentisic acid is not converted into melyl acetoacetate, right? So this conversion does not take place. And see, this is all continuation of the same tract, like phenylalanine to tyrosine, and then tyrosine into hydroxyphenyl pyruvic acid, which gets converted into homogentisic acid, and this homogentisic acid is converted by homogentisic acid oxidase into malonyl acetoacetate or malonyl acetoacetic acid, and the enzyme which is needed over here is homogentisate oxidase. And if there is deficiency of this enzyme, the clinical condition which will develop is alkaptonuria. So hereditary tyrosinemia type 2, type 1, type 3, alkaptonuria, or even your phenylketonuria here because of deficiency of phenylalanine hydroxylase. So this is all coming in the same metabolic pathway, that is from phenylalanine till the formation of fumarate and acetoacetate, right? So here, see, you can see phenylketonuria is very important from exam point of view. Hereditary tyrosinemia type 2 is very important from exam point of view, and also alkaptonuria is very important from exam point of view. So this pathway is very important for you, and you should memorize it nicely, right? So phenylalanine to tyrosine, this is phenylalanine hydroxylase. Deficiency will cause, okay, if we can just summarize the three important steps which you should know. Number one is phenylalanine conversion to tyrosine. The enzyme needed is phenylalanine hydroxylase, and if there is deficiency of this enzyme, the condition is phenylketonuria. Clear? So this is one thing. Then second thing which you should remember is tyrosine conversion to 4-hydroxyphenyl pyruvic acid or pyruvate. The enzyme needed is tyrosine amino transferase. If there is any deficiency of this enzyme, the condition which will come out is Tyrosinemia type 2. Clear? These are two important conditions. And the third important condition is conversion of homogentisate or homogentisic acid, and this is converted into melyl acetoacetic acid, and the enzyme which is needed over here is homogentisate oxidase. Clear? And if there is deficiency of this enzyme, the condition which will develop is known as Alkaptonuria. Fine? So remember 3 steps in the same pathway, and many times the questions are framed around these 3 steps only, right? So if there is darkening of urine on exposure to atmosphere, that is classically Alkaptonuria, it means there is no conversion of homogentisic acid into malonyl acetoacetic acid. And yes, when this conversion does not take place, the homogentisic acid is diverted to form benzoquinone acetate, right? So the excess of homogentisic acid, it will divert to formation of benzoquinone acetate, and the enzyme deficient is homogentisate oxidase. Clear? So please remember this important step or important concept as far as the exam is concerned. Then moving forward, glycine is present or is a component of the following substances. So here, even if you don't know the answer, we have already discussed what actually is glutamine. So we know that glutamine is composed of glutamate plus ammonia, right? So this we have already discussed. Glutamate plus ammonia forms glutamine, and obviously the enzyme which is needed is glutamine synthetase. Clear? So for glutamine, there is no need of glycine as such. So we can straightforward, we can just rule it out. But yes, if we just go with the metabolism of the glycine, we can see it is needed for the formation of creatine, it is needed for the synthesis of glutathione, and glycine also contributes to the carbon 4, 5 and nitrogen 7 of the purine ring, right? So it is contributing to the synthesis of creatine, it is contributing to the structure of purine by contributing to carbon and nitrogen, and it is also contributing to the synthesis of glutathione. So overall, glycine is very important as such. Clear? Then moving forward, most abundant amino acid in collagen. So most abundant amino acid in collagen. Now any idea here which is the most abundant amino acid present in the protein collagen? Any guesses? Anybody? Chaitanya, yes, you are partially correct, not completely. Now see, the 3 dominant amino acids are of course proline, hydroxyproline and glycine. These are the 3 dominant. Okay, and they are composed of nearly, you can say these 3 are composed of nearly 50% of the amino acid structure of collagen. But out of these 3, yes, Shrutis, you are absolutely right. Out of these 3, the most predominant is glycine, right? So although ABC, all 3 are important here, right? So glycine is also important, hydroxyproline is also important, and proline is also important. But if you talk about these three, out of these three, glycine is the most abundant amino acid in collagen, right? So please remember glycine. And yes, if someone asks you collectively, then you can answer all the three: glycine, proline, hydroxyproline. But amongst all these three, glycine is the dominant one. Okay, so please remember glycine as the most abundant amino acid which is present in collagen, right? So you can see glycine. Anyway, moving forward. Now, a chronic alcoholic, he is having generalized weakness, lethargy, has disorientation, and on examination there is global confusion, right? Then there is nystagmus and there is ataxia. Yes, the moment you have this word ataxia, or that is improper coordination between muscles, nystagmus, that is ocular movement of ocular movements, right? Dr. Mehboob, Zaim Khan, Suvankar, Kanaya, Chaitanya, everyone is right. Yes, this is classical presentation of Wernicke's encephalopathy. Clear? So this clinical presentation is classical presentation of Wernicke's encephalopathy. And yes, everyone is right. This is because of thiamine deficiency, right? That is B1 deficiency. So obviously we have to give injection of vitamin B1. Yes, so absolutely everybody is right. So the moment you have this global confusion, ocular nystagmus and ataxia, think of Wernicke's. So there is one very popular mnemonic here, right? So you can remember the global confusion, then ocular nystagmus, okay, and A for ataxia. Clear? So this way, yes, Dr. Mehboob, absolutely right. So please remember this mnemonic, and this is Wernicke's. Teja, I am uploading the PDF on my app, right? So all the PDF will be uploaded on the app after the session. Clear? So don't worry for that. So this is classical of Wernicke's. Fine. So that is classical of Wernicke's encephalopathy, and we know that Wernicke's Korsakoff syndrome, that is classically because of thiamine deficiency. Now moving forward to another question, oxaloacetate is derived from which amino acid? Now these kind of questions are slightly tough because they are very straightforward, fact based, and most of the students, they are not that good with biochemistry. So even if someone is not able to answer, I don't mind that. But if you can answer, yes, very well, Chaitanya, absolutely right. So oxaloacetate is derived from aspartate, right? So oxaloacetate is derived from aspartate, and remember, this is a reversible reaction. Kanaya, yes, absolutely right, this is aspartate, and this is a reversible reaction. It means oxaloacetate give rise to aspartate, and aspartate will be needed for production of oxaloacetate. So this is the reaction here. Aspartate will react with alpha ketoglutarate. Under the effect of the enzyme aspartate transaminase, right? So aspartate transaminase, and this will result in the formation of oxaloacetate and glutamate. Similarly, if oxaloacetate and glutamate will react, they will form aspartate and alpha glutarate. So this is a reversible reaction mediated by aspartate transaminase. So this is a kind of transamination reaction. So oxaloacetate is derived from aspartate. Then moving forward to another question, most abundant type of collagen in bone. So yes, any guesses? This is very easy to remember or very easy to understand. Let me see if someone can answer this. Most abundant type of collagen in bone. Okay, let me give you the clue. Now the answer is there in the question itself. If you look at the word bone, so how you can write it? You can write it like bone. Clear? So here you are getting the answer itself. So in bone it is type 1, right? So I think now you will never forget in your life. So the most important type or most important type of collagen in bone is type 1. Clear? So this is one thing. Now the another thing is which you can remember very easily is about type 4. So this is type 4, and type 4 can be remembered with floor. Now what structure forms the floor of any structure? That is known as the basement membrane. Clear? So this is the basement membrane. So the type of collagen in basement membrane, yes, Dr. Kanaiya, absolutely right. So the type of collagen in basement membrane is type 4, and you can remember it with the word floor, right? Type 2 is present in cartilage. Clear? So this is in you can remember like cartilage. So somewhat like this. So this is type 2 cartilage. Okay, and type 3, it is present in blood vessels. So these are the different type. Okay, thank you, Dr. Kanaiya. Right? So this is how you can type 2 for cartilage, something like that. Type 3 for blood vessels. Type 4 is for floor, that is basement membrane. But anyway, bone type 1, and also apart from bone, skin, tendon, and dental tissue, dentin. These are also type 1. So you can remember STD here. Clear? So then it's all up to you what type of mnemonic you can make. It's all up to you. So in bone it is type 1. Right? Moving forward to next question, that is about maple syrup urine disease. Right? So this is maple syrup urine disease, and this is again a very common question which has been repeated over the years. Yes, so this is branched chain alpha ketoacids dehydrogenase, right? So branched chain alpha ketoacid dehydrogenase. And very good, Dr. Kanaiya. Very good, Dr. Mehboob, Zaim Khan. Yes, everyone is correct. Very good. Now, the branch chain amino acids, which are leucine, isoleucine, and valine, the metabolism is defective because this enzyme is defective, right? And here, one of the classical presentation is that urine has got a very sweet smell, right? So it has got a sweet smell just like maple syrup. Clear? So from the maple tree, the sap of maple tree, so that is known as maple syrup, and the urine smells something like that. So therefore this condition is known as maple syrup urine disease, and this is because of deficiency of branch chain alpha ketoacid dehydrogenase. There is defective metabolism of the branch chain amino acid, which can be remembered by the mnemonic live, right? So live is the mnemonic for branch change amino acid, leucine, isoleucine, and valine. Now moving forward to another question, and this is just a repetition of the previous concept, and let me see if you can recall that or not. So which of the following is false about collagen? Now just tell me which one is the wrong. Dr. Mehboob is like is for this you have to smell the maple syrup, right? So the smell is like maple syrup, okay? Or in some descriptions that is about like burnt sugar, somewhat like that, okay? So anyway, that is, just remember, like maple syrup urine disease. So coming to question number 13, and Dr. Kanaya, yes, you are right, Dr. Kanaya, this is type 2 in tendon. This is wrong, because if you remember one of the mnemonic, that is STD, this is for type 1 collagen. Clear? So this is for type 1 collagen, and S is for skin, T is for tendon, and D is dentin, that is teeth. Clear? So tendon is also for first type 1. Clear? So tendon, again in tendon you can also get this word tendon. You can write it like this, so you will get your answer that this is type 1. Clear? And type 2 is related to cartilage, we all know that, so this is true. Type 4 is floor, that is basement membrane, and type 1 in bone, that we have already discussed, right? So tendon is type 1, please remember that. And yes, the more you practice, I think more you will be perfect. So just make sure that you don't mix up in this important concept. Now moving forward to next question. Now here a lady is having palmoplantar pigmentation, okay? So there is palmoplantar pigmentation, but more importantly there is calcification of the intervertebral disc, and on addition of Benedict's reagent there is a yellowish precipitate and a black supernatant fluid. Now here one of the important term is calcification of intervertebral disc, and if you remember one term, that is ochronosis, is what it defines ochronosis. So I think the moment you find this word ochronosis, you can think of the answer very nicely. So ochronosis is related to Alkaptonuria, okay? So there is ochronosis which is related to Alkaptonuria, and on urine test we can see a yellowish precipitate. So suppose if this is the tube, on the lower side we will have the precipitate, something like this, and on the top we have the supernatant. So the above part is known as supernatant, and the lower part is of course the precipitate. Clear? So these are the two terms, precipitate which actually precipitate down, supernatant which is above the precipitate. So here we can see a classical somewhat brownish yellow precipitate and a dark supernatant. So this is classical for Alkaptonuria, and there is presence of homogentasic acid in urine because it is not broken down into malonyl acetic acid by the deficiency of the enzyme homogentasate oxidase. So this is again one more description for Alkaptonuria. Yes, Dr. Mehboob, you are absolutely right. So this is, just remember ochronosis, and the moment you have this clue, you can jump on to the answer as yes, Dr. Kanaya, there will be pigmentation of cartilage. You can see pigmentation of ears, okay, or skin. Pigmentation can be seen. This is just because of deposition of the pigment. Okay, so that is also one finding. So this is Alkaptonuria. So sometimes you don't have that classic word like discoloration or dark discoloration of the urine on exposure to atmosphere. So this is how you have to search out the clues to reach up to the answer. And there is pigmentation in the cartilage as well. Then another question was like a protein specimen was heated to a temperature till 100 degrees Celsius. Now we know that there are 4 structures of the protein, like primary, secondary, tertiary and quaternary structure. So if we heat a protein sample till 100 degrees Celsius, which structure will never be denatured? So I think the answer is pretty easy. The simplest or the basic structure of the protein will never be destroyed, right? So here the answer will be primary structure. And what is primary structure? Dr. Kanaya, absolutely right. Primary structure is what? It's a polypeptide chain. There are many amino acids which are joined by peptide bond. So that is the simplest of all structures of the protein. That is the primary structure. Zaim Khan, Dr. Kanaya, absolutely right. This is primary structure. And then secondary structure is what? Alpha helix or beta pleated. So whenever there is coiling or folding of the primary structure, it becomes tertiary structure. Then it becomes secondary structure. Then tertiary structure is what? 3-dimensional configuration of the single polypeptide chain. And quaternary is spatial relationship between the 2 polypeptide chains. So when we talk about primary, say this is simple is primary. If I want to make it tertiary, there will be a alpha helix or it will be beta pleated, right? So this is alpha, this is beta. And then in tertiary, there is coiling of the single polypeptide chain. And in quaternary, there are more than 1 polypeptide chains. Like suppose if this is 1 polypeptide chain and there is another polypeptide chain as well. So this becomes quaternary. Clear? So these are the different structures of protein. So this is primary, this is secondary, this is tertiary, and this is, you can say, quaternary. Clear? So out of all these structures, when you heat a sample to above 100 degrees of Celsius, the secondary, the tertiary and the quaternary will be destroyed. There will be denaturation of protein, and what will be left? The simplest, that is the primary structure of protein. Clear? So primary, secondary, tertiary and quaternary. Now another question is, which of the following protein does not have a quaternary structure? Which protein does not have a quaternary structure? It means there is only a single polypeptide chain having 3-dimensional folding pattern. Zaim Khan, absolutely right, gentlemen. This is myoglobin. See, hemoglobin is, we know that there are alpha chains, beta chains, so that is classical. Collagen, insulin, everything is quaternary structure, but myoglobin is having only tertiary structure. And when I say tertiary, it is a single polypeptide chain which is having 3-dimensional configuration because of different chain interactions or bondings, right? So myoglobin does not have a quaternary structure. Please remember that. So in myoglobin, there is only tertiary structure, and this is how you can see there is 3-dimensional structure of myoglobin. And myo means muscle, so it is predominantly found in muscle tissue, right? Anyway, then next question, a child has frequent attacks of convulsions and unconsciousness. He has poor intake of food, and therefore there will be loss of weight, difficulty in learning and fatigue. The urine is having a sweet smell, Again, I think Mehboob will understand this, right? And there is high level of leucine, right? So again, high level of leucine means leucine is not broken down, and we know that which enzyme is needed for breakdown of leucine or isoleucine or valine. This is branched chain alpha keto acid dehydrogenase. So this is branched chain alpha keto acid dehydrogenase. Clear? So this is again the description is for maple syrup urine disease. Clear? So this is the diagnosis here, and this is the enzyme which is deficient. So I think there should be no confusion in this question. Yes, Zaim Khan, absolutely right. The answer is A. Then next question, which pathway occurs only in cytoplasm? Now this is a very easy question. I think most of you can answer this. For question number 18, which pathway occurs only in cytoplasm? Now, yes, anyone? Chaitanya, yeah, you are absolutely right. So this is glycolysis. And what is glycolysis? That is breakdown of glucose. Yes, Kanaya, absolutely right, gentlemen. So glycolysis. Now what is glycolysis? Glyco and lysis. So glyco is actually sugar, lysis is breakdown. So the glucose is finally break down into a pyruvate if the conditions are aerobic, or it can get converted into lactate if the conditions are anaerobic, right? So this is breakdown of glucose, and this occurs in cytoplasm. Now all these three pathways, gluconeogenesis, urea cycle and heme synthesis, they occur in both mitochondria and then cytoplasm. Clear? So they have the dual sides. Gluconeogenesis, that is formation of the sugar from the non-sugar sources like pyruvate, lactate, alanine. Urea cycle, we have already discussed, that is breakdown of ammonia into urea. And heme synthesis, as the name suggests, synthesis of heme, right? So these option B, C, D, they occur in both the sides, mitochondria plus cytoplasm. So glycolysis is the answer here. So please remember glycolysis. Then moving forward to another question, insulin increases activity of all of the following enzyme except. So which of the enzyme activity is not promoted by insulin? Now here the basic concept is that firstly we should know what is the action of insulin. Insulin tries to decrease blood sugar level, right? It will try to reduce the blood sugar level, and it will not promote any step or any pathway or any enzyme which is involved in the synthesis of sugar, right? So here it is never interested in promoting pyruvate carboxylase, because this is one enzyme which is needed in gluconeogenesis. So this is needed in gluconeogenesis, because if we talk about the definition of gluconeogenesis, so if we write about gluconeogenesis, this is synthesis of, you can say, new sugar, because new word is here, but from non-sugar sources. Clear? So, and non-sugar sources, you can remember a mnemonic LPG. So L is for lactate, P is for pyruvate, G is for glycerol. Clear? So although alanine is also an important substrate, right? So this is the meaning of gluconeogenesis. Now when we say pyruvate, it can only enter into gluconeogenesis when there is involvement of this enzyme pyruvate carboxylase. So since the pathway of gluconeogenesis involves conversion of pyruvate into oxaloacetate by the involvement of pyruvate carboxylase, so insulin will never promote this enzyme, because if this enzyme is promoted, obviously insulin will be promoting gluconeogenesis, which is doesn't want. So insulin is never favoring gluconeogenesis. So it will never favor any enzyme which is a component of this pathway. So therefore, insulin will never increase the activity of pyruvate carboxylase. Clear? So that is the concept behind this. Now, phosphofructokinase, glucokinase, these are all involved in glycolysis, which is actually breakdown of glucose. So insulin is very happy with those enzymes. Clear? So please remember, this is the concept for this particular question. Now next question. A fellow has elevated levels of cholesterol. So cholesterol level is high, and obviously there is an increased risk of heart disease, we all know. And his elder brother also had similar findings and he died because of this. So it means this condition is familial, right? Brother is having, so this condition is running in family, so this is familial. And there is LDL receptor deficiency. So there is LDL receptor deficiency. Now cholesterol levels are high, so you can write hypercholesterolemia, that you can just simply write as such. So this is the condition, familial hypercholesterolemia. So this is primary familial hypercholesterolemia, which is type 2A hyperlipoproteinemia. Now here actually what happens, the LDL receptors on the liver, they are responsible for intake of the LDL within the liver. And if there is any deficiency of these receptors, obviously the LDL will remain in the circulation. And LDL carries cholesterol. So ultimately cholesterol level will be high in the body. So here actually, in short, you need to remember about transport of endogenous lipids, because previously we discussed about exogenous lipids which were taken in the diet and they were transported by chylomicrons. But endogenous lipids which are synthesized in liver, now these lipids, as we all know, that these are non-polar, they cannot mix in blood. So there has to be a protein covering which is polar and which helps them in transportation in the blood. So the endogenous lipids, which are again triglycerides and very less amount of cholesterol, they are covered by apoprotein B100. So this is apoprotein B100. Clear? And again, if I draw it in terms of the percentage, so this is again triglyceride, very less is cholesterol, so this is the cholesterol, and the covering is apo B100. So this is the covering here. Clear? So this structure is known as VLDL. So the endogenous lipids which are synthesized in the liver, they are converted into VLDL, and this is the form in which it is transported in blood. Now VLDL will be again acted upon by the lipoprotein lipase. So this will be acted upon by lipoprotein lipase, and we know that what is the effect of LPL, it will try to remove triglycerides out of this assembly. So after some time, what we will find, there will be reduction in the amount of triglycerides and there will be increase in the amount of cholesterol. So this is, you can see, almost 50-50 now. So this assembly is now known as, again the covering is ApoB 100. So this is now known as IDL, that is intermediate density lipoprotein, or we can also call it VLDL remnant. Clear? So this is VLDL remnant. Now still the lipoprotein lipase is not satisfied. It will continue to act. So lipoprotein lipase will continue to act, and we know what is the effect. It will keep on removing the triglycerides, and a time will come when the triglycerides will be very less and the entire structure will be, almost entire will be cholesterol. So you can see triglyceride is very less. Now this assembly is known as LDL, right? So this is LDL, and you can see LDL is mainly composed of cholesterol, and therefore it is known as bad cholesterol because it is mainly composed of cholesterol. Now this LDL can move inside liver, but by the way of LDL receptors, and to bind to these LDL receptors there is ApoB 100, which is the ligand. So only this structure will help binding of LDL to LDL receptors over the liver. If there is any problem either with these, either LDL receptors are defective, either ApoB 100 is defective, LDL will never enter into the liver. It will remain in the circulation. It will go to the peripheral tissues where it can get deposited, mainly into the coronary vessels where it causes coronary artery disease, right? So this is how the pathology of type 2A hyperlipoproteinemia develops. And for endogenous lipids, the transport form is VLDL, and for cholesterol it is mainly the LDL form, which is having the cholesterol mainly, right? So here if we say hypercholesterolemia, it means there is excess of LDL, because LDL is mainly composed of cholesterol. Ideal is 50% triglyceride, 50% cholesterol. VLDL is, you can say, 95% triglycerides, 5% cholesterol. So this is how, depending on the lipoprotein, we can think of the lipid which will increase in the body. If there is excess of low density lipoprotein, you can say with surety that there will be excess of cholesterol in the body, and that condition is primary familial hypercholesterolemia. Clear? So the concept is little detailed and confusing, but if you try to understand it, it is very simple, right? So this is how you can remember type 2A. So I am just restricting myself to this entity because otherwise it will take a lot of time and it will be more confusing as well. So in type 2A, there is excess of LDL, and we know that LDL is composed mainly of cholesterol. So cholesterol will be very high. In LDL, triglyceride is very less, so triglycerides level will be normal, and this bad cholesterol can go and it can deposit into the coronary arteries, though there is very high risk of atherosclerosis. So please remember, primary familial hypercholesterolemia. So this is the most important one, which is very frequently asked in exam, type 2A. Anyway, moving forward, an infant, it presents with hepatomegaly, that is enlargement of the liver. Hypoglycemia, it means low blood sugar levels. Hyperuricemia, high uric acid levels. And lactic acidosis. There is increased amount of lactate in the blood. And when we did a liver biopsy, we found that the structure of glycogen is normal. Now, which enzyme is deficient in such a case? Any idea? Liver enlargement, low blood sugar, high uric acid, increased lactic acid. Yes, Dr. Zaz, Dr. Mehboob. Yes, Dr. Mehboob, you are absolutely right. This is glucose 6 phosphatase. Now, this is classical description of von Gierke's disease. Right? This is classical description of von Gierke's disease, which is because of deficiency of glucose 6 phosphatase, which is the ultimate, or the, you can say, the final one of the final steps which is needed for conversion of glucose 6 phosphate into glucose, right? So here we can see this is the step which needs glucose 6 phosphatase. So if this step is blocked, it means sugar level will reduce in the body. So as a result of this, there is hypoglycemia in the patient. Number one. Number two, when this glucose 6 phosphate level in the body is high, because it is not being converted into glucose, so this level will be high. Now this glucose 6 phosphate will enter into alternate pathways. And here I would like to tell you one thing. Suppose if there is a substance A which is converted into the substance B, usually say by the enzyme X. Now this is the normal pathway. Okay, and if this X is not working, then obviously the level of A will increase in the body, and then what will happen? This will go and it will divert towards forming some other substance. So this what usually happens whenever there are enzyme deficiencies, because the initial substrate, it will keep on accumulating and then it will search for some alternate pathway for consumption. So the same is happening here. The glucose 6 phosphate, which was normally supposed to get converted into glucose by the involvement of the enzyme glucose 6 phosphatase, now this glucose 6 phosphatase is not working nicely. So there is high level of glucose 6 phosphate, and then it will enter into alternate pathway. One of the pathway is formation of ribose 5 phosphate, which is ultimately leading to the production of uric acid. So as a result of this, there is increased formation of uric acid, what is written here. So this glucose 6 phosphate forms uric acid. Glucose 6 phosphate is not forming glucose, so there is hypoglycemia, right? So we can correlate 2 points here. And also then this glucose 6 phosphate will get converted into pyruvate, which will form lactate. So there will be lactic acidosis. So this point can also be discussed here. So hypoglycemia, hyperuricemia, lactic acidosis, this will all happen in von Gierke's disease, which is because of the deficiency of glucose 6 phosphatase, right? So this is a very complex pathway, but remember this principle: if A cannot get converted into B, it will take a alternate pathway and it will get converted into C, which will create some problems. Clear? So this is how you can remember here. Now the glycogen structure is normal. It means there is a complete breakdown of the glycogen structure as such. So because we know that glycogen is broken down, that is glycogenolysis. Clear? So this process is glycogenolysis. So here the breakdown is occurring normally. It is only till the last step where the glucose 6 phosphate is not converted further into glucose. So glycogen structure is not broken halfway down, so it doesn't have a normal it doesn't have an abnormal structure. It is normal. This is also one important clue here. So normal structured glycogen. So remember, Wernicke's G6P deficiency, and don't mix it with G6PD, which is altogether a different pathway. Clear? Then moving forward to another question, a patient has bony pain, and there is enlargement of liver and spleen, and when we examined the splenic tissue, we saw crumpled tissue paper appearance. Now, what is this condition? So firstly, you have to tell me the condition. What is this condition? Crumpled tissue paper. Very classical word, crumpled tissue paper. The moment you have this very valuable clue, I think you need not look here and there. You can straight away, you can jump to the answer. So crumpled tissue paper. Yes, anyone? What is this condition? Very good, Zaim. This is Gaucher's disease. Right? So this is Gaucher's disease. And here there is deficiency of the enzyme glucocerebrosidase, which is, therefore, there is no breakdown of glucocerebroside and it gets accumulated. Clear? So there is accumulation of glucocerebroside as there is deficiency of glucocerebrosidase. So deficiency of glucocerebrosidase, and glucocerebrosidase is needed for breakdown of glucocerebroside. So this is the Gaucher's disease, and you can see a classical crumpled tissue paper appearance of the Gaucher cells, which will deposit into the bones, and therefore the patient will have bone pain. Okay, it will deposit into the liver, so there will be hepatomegaly. So this is how you can correlate the 2 points, why there is bone pain, why there is enlargement of liver, and the glucocerebroside cannot be broken down because there is deficiency of glucocerebrosidase. So this is the classical Gaucher's disease. Then next question, a neonate after few days of birth becomes lethargic and is refusing breastfeeding, and the moment he is breastfed forcibly, he vomits, and the child is also having diarrhea, and there is oil drop cataract. The moment you have this kind of presentation, I think the diagnosis is pretty obvious. There should be no confusion whatsoever. Neonate, unable to digest breast milk, there is diarrhea and oil drop cataract. Very good, Zaim Khan. Very good, Dr. Kanaya. This is galactosemia. Right? So this is galactosemia. And the most common enzyme defect is, galactose 1-phosphate uridyl transferase. So the child is not able to digest the galactose which is present in the breast milk. So intolerance to breast milk, and therefore we say in galactosemia, don't breastfeed, because the child will not be able to digest that. So why to give breastfeed? So don't breastfeed. Next question, a patient is having pain in the calves during excessive exercise but without any other sign or symptom. Now in muscle biopsy there is increased glycogen. Which enzyme is deficient? I think very straightforward question. The answer is pretty simple. There is very good, Zaim Khan. There is involvement of only muscles. Right? There is involvement of muscles, and the glycogen which is present in the muscle, it is not been broken down, and this is because in muscle there is one enzyme, that is muscle phosphorylase. So if there is deficiency of muscle phosphorylase, the glycogen will not be broken down, and hence the patient will develop only symptoms related to muscle, that is pain in the muscles, which specifically comes after excessive or heavy exercise, right? So Dr. Mehboob Saeem Khan, please remember this is muscle phosphorylase, and the classical picture is only muscle symptoms, no other symptoms either related to liver or any other thing, right? So classical muscle involvement, that is the classical word here, muscle involvement. So the symptomatology is in accordance with that. So very easy to diagnose, muscle phosphorylase, that's it, okay? And then moving forward to the last question, a child is having aggressive behavior and is having poor concentration, there is joint pain, reduced urinary output, and there is a self-mutilating behavior, and the child used to damage or mutilate his fingers. Very good, Zaim Khan. This is a classical description for which condition? This is actually Lesch-Nyhan syndrome, right? So this is because of Lesch-Nyhan syndrome, and there is classically hypoxanthine guanine phosphoribosyl transferase deficiency, right? And one of the important feature is increased uric acid, and second important classical feature is self-mutilating behavior. The child will bite his lip, will bite his fingers. So this is the classical picture here. You can see the child is, has bitten his lips and even his index finger. So that is classical for Lesch-Nyhan syndrome, which is because of deficiency of hypoxanthine guanine phosphoribosyl transferase. And there is, you can see, raised uric acid. The symptomatology is somewhat like gout. Clear? So I think this is enough for this session, and I'm extremely thankful to all of you for spending your valuable time with me so much late in the night. And I'll come with the next session that will be based on pathology PYQs. So till then, keep on studying. God bless. Bye bye. Good night.